Hello, everyone, and welcome to our module on cardiac physiology. Shown on the screen is an echocardiogram image of the left ventricle as it contracts over and over through the cardiac cycle. And so this black space in the middle is the amount of blood inside the left ventricle. And you can see that sometimes the amount of blood shrinks as blood is being pushed out of the chamber, and other times the amount of blood expands as the chamber is filling. And so that process of the left ventricle filling and shrinking and filling and shrinking is the cardiac cycle, and that's the basis of cardiac physiology, and that's what we're going to talk about in this video today. One of the most important things for understanding cardiac physiology is simply knowing terms associated with the cardiac cycle. So let's start by going through some of the important terms related to cardiac physiology, and we'll start by talking about the volumes inside the heart, specifically inside the left ventricle. So if you look at this drawing on the screen and we focus on the image on the right, when the left ventricle fills during diastole, it fills until it reaches some maximum volume of blood inside the chamber. And we call that volume the end diastolic volume. It's the most amount of blood that will fill the left ventricle during the cardiac cycle. It's the amount of blood in there at the end of diastole when filling has been completed and contraction is about to begin. Now, if you look at this image on the left side of the screen, this depicts what happens at the end of systole. So systole is when the left ventricle contracts and pushes blood out of the chamber into the body. So it's going to do that until the amount of blood inside the chamber has reached some minimum volume, the smallest volume of blood the chamber will hold during the cardiac cycle. And we call this the end systolic volume. It's the volume inside the left ventricle when emptying has been completed and the chamber is about to begin relaxing and filling once again. So these two volumes, the end systolic volume and the end diastolic volume, are very important in physiology because during the cardiac cycle, the chamber goes back and forth between these two volumes. We can also use these two volumes to define an important term called the left ventricular ejection fraction. This is basically the percentage of blood that the left ventricle ejects with each squeeze of the chamber. So the left ventricular ejection fraction is equal to the difference between the end diastolic volume, that's the maximum volume of blood in the chamber, and the end systolic volume, the smallest volume of blood in the chamber. And then we divide that by the EDV and multiply by 100. So let's imagine that the end diastolic volume is 100. I'm just going to make some numbers up here. Let's imagine that the end systolic volume is 50. Then the left ventricular ejection fraction would be 100 minus 50 divided by 100. This would be 0.5. We'd multiply that by 100 to say that the left ventricular ejection fraction is 50%. And a normal left ventricular ejection fraction for a healthy heart is about 55 or 60%. The left ventricle never ejects all the blood inside the chamber. It can't do that. It ejects about 55 or 60%. So besides the ejection fraction, we can use the end diastolic volume and the end systolic volume to describe some other terms. One important term is the stroke volume. This is the amount of blood ejected with each cardiac cycle. So this is equal to the end diastolic volume minus the end systolic volume. And then we can also define an important term, the cardiac output. That's the stroke volume times the heart rate. So this is the volume of blood per minute that the heart is ejecting. That's the cardiac output. Some other important terms are shown on this slide. First of all, let's talk about venous return. This is the blood that is returned to the left ventricle or to the right ventricle, depending upon which chamber you're talking about. But it's the blood that's returned to the heart with each cardiac cycle. And it should equal the cardiac output. In other words, the volume of blood pushed out of the left ventricle with each cycle should equal the amount of blood that comes back to the left ventricle with each cycle. Another important term is the total peripheral resistance, or TPR. This is the resistance to blood flow from peripheral structures. So when the left ventricle tries to push blood out of the heart, that blood exiting the heart is resisted by structures in the periphery. And the total resistance of all those structures is called the total peripheral resistance, or TPR. The major vessels that determine the TPR are the arterioles. These are the resistance vessels of the arterial tree. So when there's constriction, when there's vasoconstriction of the arterioles, that tends to raise the TPR. And when there's vasodilation of the arterioles, that tends to reduce the TPR. And then just so you don't get confused, some books will refer to the TPR as the systemic vascular resistance, or the SVR. These two terms mean the same thing. Now let's talk about some terms related to blood pressure. So if you look at this chart on the screen here, it shows how the blood pressure goes up and down in a patient with each cardiac cycle as the heart contracts, as shown by the EKG at the top. And so the highest pressure that the blood pressure achieves is called the systolic blood pressure. And you should be aware, especially for step 1, that this value, the systolic blood pressure, is largely determined by the stroke volume. As blood leaves the left ventricle, that tends to drive up the blood pressure in the central aorta until it reaches a maximum value. The more stroke volume there is, the higher this systolic blood pressure will reach at its peak. The less stroke volume there is, the lower that value will be. And then the lowest blood pressure that occurs in the central aorta is called the diastolic blood pressure. And you should be aware that this is largely determined by the total peripheral resistance. And so I've cleared away my ink here so you can see that the central blood pressure falls until it reaches the lowest value. That's the diastolic pressure. Well, if there's a lot of TPR, then blood can't flow out of the central aorta. In other words, it can't leave the arterial tree very easily, and so that will cause the diastolic pressure to be higher. In other words, when there's a lot of peripheral resistance, then the blood pressure does not get as low as it could, and the diastolic blood pressure tends to be higher. On the other hand, when there's very low peripheral resistance, then blood leaves the arterial system very easily and tends to achieve a much lower blood pressure in diastole. And then finally, let's talk about the pulse pressure. That's the difference between the systolic blood pressure and the diastolic blood pressure. So for example, if the systolic blood pressure were 120 and the diastolic blood pressure were 80, then the pulse pressure would be 40. And you should know, especially for step 1, that pulse pressure is proportional to stroke volume. The larger the stroke volume, the higher the pulse pressure. The smaller the stroke volume, the lower the pulse pressure. Patients who have heart failure and have a very low stroke volume, a very low cardiac output, they tend to have a very small or low pulse pressure. Another important blood pressure term is the mean arterial pressure, or the MAP. This is equal to the diastolic blood pressure plus 1/3 of the pulse pressure. In other words, plus 1/3 of the difference between the systolic and the diastolic pressure. If you look over here at this graph, this shows how blood pressure changes over time in the body. And it turns out that we spend more time in diastole than we do in systole. So when you're determining the mean arterial pressure, it's not going to be right in the middle between the systolic and the diastolic pressure. It's actually going to be closer to the bottom. And that's because we spend more time in diastole. And that's why you use this formula here to determine the mean pressure. So for example, if a patient had a blood pressure of 120/80, the MAP would be equal to 80 plus 1/3 of the difference, which is 40, and that would be 93.3. Okay, now let's talk about the cardiac output, which is a very important physiology parameter. And that's because the cardiac output has to rise to meet demands. So when we exercise, the cardiac output has to go up. When we're resting or sleeping, the cardiac output goes down. And as I told you earlier, the cardiac output is equal to the heart rate times the stroke volume. So you can change cardiac output either by modifying the heart rate or by modifying the stroke volume, or both. And this is very important when we talk about disease states, especially ischemia and angina, which I talk about in other videos, because more cardiac output means more work is required for the heart to do its job, and therefore more oxygen is required. So if either of these two parameters change, if there are more beats per minute, then that means more work for the heart. And if there's more stroke volume per beat, that also means more work. And so this is going to be very important as we talk about changes in physiologic and pathologic states that alter the cardiac output. So what determines the cardiac output? Well, there are 4 determinants, and these you have to know for step 1. These are extremely important in cardiac physiology. The 4 determinants of the cardiac output are the preload, the afterload, the contractility, and the heart rate. Now, the heart rate is fairly obvious, but we're going to talk about in the next few slides these 3 parameters and what they mean and how they change to modify the cardiac output. So preload means exactly what it sounds like it means. It means the amount or the volume of blood that's loaded into the left ventricle with each cardiac cycle. It can also be defined as the degree of stretch on the fibers, the myocardial fibers in the ventricle prior to contraction. That's because the more volume you put in the left ventricle, the more you stretch those fibers. Some books will say length instead of stretch, but it means the same thing. It's how much stretch are you putting on the myocytes by filling it with a large volume of blood. That's the preload. And anytime there's more preload to the left ventricle, that's going to generate more cardiac output. The two go together. Less preload, less cardiac output; more preload, more cardiac output. And then if you look at what I've shown on the screen here, this is the very important information that you want to know about preload. Anytime you raise the preload, you fill the ventricle more in diastole. That's going to raise the end diastolic volume that we talked about earlier. And remember, the stroke volume is equal to the end diastolic volume minus the end systolic volume. So what this means is anytime you raise preload and you raise the end diastolic volume, you're going to raise this number and you're also going to increase the stroke volume. Preload and stroke volume and cardiac output go together. When one goes up, the others go up as well. And then as I mentioned earlier, when there's more preload, the heart has to do more work. You're filling it with more blood. It has to pump harder. It has to work harder. So increasing preload will raise the work of the heart and increase the amount of oxygen required for the heart to do its job. So preload is a theoretical concept, but now let's talk about some actual ways we could increase preload in actual human beings or patients. So one of the first ways to increase preload is to simply add volume to the body. So if you infuse a unit of blood in a patient or you administer IV fluids like normal saline to a patient, that's going to increase the amount of volume in the body. It's going to increase the amount of volume going back to the heart, and that's going to raise the preload. This is going to increase the LV/EDV, just like we talked about on the last slide, and do all those things we talked about that happen when preload goes up. Another way to raise preload that's less obvious is to constrict veins. So the veins in our body hold a very large volume of blood, and if they constrict, they will push that blood out of the venous system and back into the heart, and that's going to increase the preload. And this is one of the major ways that our body responds to blood loss. So if you lose blood, then the sympathetic nervous system will stimulate receptors on your veins, and the veins will constrict. This is done through alpha-1 receptors in the veins. And when those veins constrict, they push blood back into the heart and they raise the preload, which, as we talked about on previous slides, that's going to increase the cardiac output, which is a good thing if a person has lost blood volume. And so these are really the two most clinically important ways that we increase preload. Another way that's less important clinically, but it comes up in physiology, is that anytime you slow the heart rate, the heart spends more time in diastole, and that allows for more filling of the left ventricle, and that means more preload and more volume. So this isn't really important clinically that much. We don't slow people's heart rates often to raise their preload, but you should be aware that for physiology purposes, anytime the heart rate slows, that's going to result in more preload. So the key parameters of what determines your preload, the things that you want to know are, first of all, the LV/EDV. That's how much blood is coming back into the left ventricle at the end of diastole. That's a marker of your preload. The other important marker is the venous tone, or how much constriction there is on the veins. This also determines what the preload will be because it determines how much blood will be pushed out of the venous system and into the heart. What about the opposite? What are some ways that preload can decrease in actual patients? Well, one is if volume of blood is removed from the body. Patients who are bleeding or who are dehydrated, they will have a low LV/EDV and they will have low preload and low cardiac output. You can also reduce preload by pooling blood in the veins. This is the mechanism of action of nitrate drugs like nitroglycerin, which I talk about in the videos on ischemia. These drugs relieve angina, and the reason they relieve angina is because they dilate the veins and they pool blood in the veins. This lowers the preload, and when there's less preload, there's less work for the heart, and that's helpful in patients who have angina. And then finally, you can also decrease preload by raising the heart rate. This leads to less time in diastole and less filling. This is the least important of the three ways to decrease preload, but this is important for physiology purposes. So I've hinted at this on the last two slides, but I just want to emphasize this point because it's really important. In terms of preload, the two important terms are the LV/EDV and the LV/EDP. The LV/EDV is the volume of blood in the left ventricle when it has completed filling at the end of diastole, and the LV/EDP is the pressure in the left ventricle when it has completed filling at the end of diastole. These two terms are markers of preload because the more you fill the left ventricle, the more the volume will go up. And when there's more volume in the chamber, there will be more pressure on the walls of the chamber. And so the LV/EDP will go up. So you can kind of think of these two terms as markers of preload. They go up when preload goes up. They go down when preload goes down. Now let's move on from preload and talk about afterload. Afterload is another one of the four determinants of stroke volume and cardiac output. An afterload refers to forces that resist the flow of blood out of the left ventricle. So when the left ventricle squeezes, this raises the pressure of the blood in that chamber, and then that higher pressure will open the aortic valve and drive blood into the aorta and out into the periphery. And the forces that resist all of this from happening are collectively called the afterload. So if you want to think about afterload, just think about the fact that it's harder to push blood out of the left ventricle if the blood pressure is high. This could happen if there's a lot of peripheral resistance from arterioles. It's also hard to push blood out of the left ventricle if the aortic valve is stiff. A stiff aortic valve generates a lot of afterload. And then finally, there's a lot of afterload, and it's hard to push blood out of the left ventricle if something's in the way of blood flow. This happens in rare situations like hypertrophic cardiomyopathy or subaortic membranes, and I talk about these things in other videos. But basically, all these things I've described here represent high afterload. In other words, lots of forces resisting blood leaving the left ventricle. And anytime this happens and it's chronic, that leads to hypertrophy of the left ventricle, which I talk about in another video. But chronically high afterload, for example, in patients who have chronically high blood pressure, that will lead to a thick left ventricle and hypertrophy. And so over here, I've written the things you want to remember about what happens when afterload goes up. When afterload goes up, it's harder for blood volume to leave the left ventricle. That means at the end of systole, there will be more blood left behind in the left ventricle and the end systolic volume will go up. This always happens when afterload gets higher. Also, when afterload gets higher, there's less stroke volume and less cardiac output. This can be confusing. It's different from preload. We said when preload goes up, stroke volume goes up. The opposite is true for afterload. When there are more forces resisting the flow of blood volume out of the left ventricle, the stroke volume will fall. And then finally, anytime there's more afterload, it's going to require more work for the left ventricle to push blood out to the body, and there's going to be more oxygen required. So anytime the afterload is high, that makes the heart have to work harder to do its job and push blood out to the body. So what are some ways that afterload increases in real life? Well, one way is if the mean blood pressure goes up. I said this before. Patients who have chronically high peripheral resistance or chronically high blood pressure, those patients always have to do more work for their heart because they have high afterload. Another way afterload goes up is when there's an obstruction to outflow from the left ventricle. So patients who have aortic stenosis, like what's shown on the screen here, they have a stiff aortic valve. It's very hard for blood to get out of the left ventricle. That represents high afterload. Patients who have certain variants of hypertrophic cardiomyopathy, which I talk about in another video, those patients can have a thick left ventricular wall that obstructs the flow of blood out of the ventricle. That also represents high afterload. And then the ways we decrease afterload in patients are the opposite of what I showed you on the last slide. So when you lower a patient's mean blood pressure, you are reducing the afterload on the heart and making it easier for the heart to do its job. You also decrease afterload when you treat aortic valve disease, for example, when patients have aortic valve replacement surgery for a stenotic aortic valve, or if you treat obstruction and hypertrophic cardiomyopathy. All of these things will decrease the afterload and reduce the work that the heart has to do. Okay, our next one of the 4 determinants of stroke volume and cardiac output is contractility. This refers to how hard the heart muscle squeezes. The more that the muscle in the left ventricle squeezes, the more contractility there is, and the more stroke volume the heart will produce. And I talked earlier about the ejection fraction, and that's basically an index of contractility. Patients with high contractility, for example, patients who are exercising, will have a very high ejection fraction. Patients with poor contractility, like patients with heart failure, will have a very low ejection fraction. And the major regulator in the human body of contractility is the sympathetic nervous system. There are beta 1 receptors found on myocytes, and when those are activated by the sympathetic nervous system, the heart squeezes harder and contractility goes up. In addition to the sympathetic nervous system increasing contractility, it can also increase heart rate, which we'll talk about in a minute. So through both of these effects, raising heart rate and increasing contractility, the sympathetic nervous system has a lot of control over our cardiac output. And once again, I've shown on the screen here the things you want to remember about what happens when contractility goes up. When contractility rises, the ventricle pushes out more blood in systole. So at the end of systole, there will be a lower end systolic volume. When contractility goes up, also because more blood is pushed out of the left ventricle, the stroke volume will go up. And then finally, because the muscles are contracting more vigorously when contractility goes up, this leads to more work required for the heart and more oxygen required. So the main way that we increase contractility in the human body is through the sympathetic nervous system. It has innervation to the heart, like I mentioned on the last slide. It can also drive the adrenal glands to produce circulating catecholamines like epinephrine and norepinephrine. And all of these things will increase the contractility of the left ventricle. What they do is they act on myocytes to increase calcium release from sarcoplasmic reticulum. I talk about this in other videos. And so anytime we're under any kind of stress, whether that's physiologic or pathologic or we're exercising, all these things are going to activate the sympathetic nervous system and raise contractility. We also have drugs that mimic the sympathetic nervous system. These are called sympathomimetic drugs. Drugs like dopamine, dobutamine, epinephrine, norepinephrine. All these things are going to raise contractility. And then finally, in some of the heart failure videos, I talk about digoxin. This is a unique drug that inhibits the sodium potassium pump found in myocytes. It raises the amount of calcium in myocytes, and that also increases contractility. If we want to decrease contractility, one of the major ways we do this is through drugs that block the sympathetic nervous system, especially beta blockers. These block the activity of the sympathetic nervous system on the heart, and therefore they lower contractility. We also do this with calcium channel blockers, drugs like verapamil and diltiazem, which I talk about in other videos. These lead to less calcium inside myocytes for muscle contraction, and therefore they reduce contractility. Heart failure is a condition of poor contractility, systolic heart failure especially. These patients always have poor contractility and a low stroke volume and cardiac output. And then finally, when the human body is very sick overall, this often leads to reduced contractility in the heart. So for example, if there's hypoxia from poor oxygenation, if there's hypercapnia, which means a high carbon dioxide level from poor ventilation, that can decrease contractility. And anytime the blood is acidotic, that also reduces contractility. So I've jumped back to this slide for a minute, showing you the 4 determinants of cardiac output. It's super high yield to know these 4 items shown in this slide. We've talked about these 3 right here. Now let's talk about the last one, which is heart rate. So the heart rate is one of the main ways that we increase cardiac output under physiologic conditions. If you've ever gone to the gym and exercised, you've probably noticed that your heart rate goes up, and that's because your body is raising the heart rate to raise the cardiac output to meet the demands of your muscles. And just like contractility, heart rate is mainly regulated through the sympathetic nervous system, and it's increased by sympathomimetic drugs. It's also decreased by beta blockers and calcium channel blockers, just like I talked about for contractility. And so anytime the heart rate goes up, hopefully it's fairly obvious to you that that means the work of the heart is going to go up and the amount of oxygen that's required is going to go up. Now let's talk about what happens to the volumes in the left ventricle when you raise the heart rate. So if you could raise the heart rate in isolation, meaning you could raise the heart rate but not modify contractility after load or preload at all, what would happen is the end diastolic volume would fall. This would happen because at high heart rates, there's less diastolic filling time for the left ventricle, so the EDV will fall. And since the stroke volume is equal to the EDV minus the ESV, when the EDV falls from higher heart rates, you would also see a fall in stroke volume. So once again, if we could change heart rate in isolation without a change in contractility, we would see a relationship between stroke volume and heart rate that looks like this. But this never happens in real life because in human beings, anytime you change the heart rate, you also modify contractility. Remember that the sympathetic nervous system is the major controller of heart rate and contractility. So anytime the sympathetic system increases the heart rate, we also get an increase in contractility. And what this means is that our stroke volume rises with higher heart rate. In real life, in actual human beings, the relationship between heart rate and stroke volume looks like what I've shown on the slide here. And that's because when we raise the heart rate, we also raise contractility, and the contractility increases the dominant effect such that stroke volume goes up at a higher heart rate. And this should make sense to you. If a higher heart rate led to a lower stroke volume, why would your heart rate go up at the gym when you need more cardiac output? Obviously, you know from exercising that a higher heart rate leads to more cardiac output. And that's because of this relationship shown in this slide here and the fact that heart rate and contractility changes are linked together by the sympathetic nervous system. So once again, just to make this point very clear, when you raise the heart rate in the physiologic range, such as in a person with exercise, this is associated with a rise in cardiac output. And that's because when you raise the heart rate, this is done through the sympathetic nervous system, which also increases contractility, and the contractility effect helps to raise the cardiac output. So in the physiologic range shown in blue here, the relationship between cardiac output and heart rate is a linear increasing slope, just like what I've shown in this slide. The only time a higher heart rate leads to a fall in cardiac output is at pathologic heart rates. So the human heart is not meant to beat 300 times a minute. We can never achieve that heart rate physiologically by running at the gym. The only way you're going to get a heart rate in the 250 to 300 beats per minute range is if you have some type of arrhythmia. And when arrhythmias drive the heart to beat very, very fast, and once again, I'm talking about heart rates close to 300 beats per minute, that's a pathologic range. And when the heart's beating that fast, there's not enough time for the left ventricle to fill. And so these higher heart rates start to lead to a drop in cardiac output. And this is why people who have arrhythmias like ventricular tachycardia can pass out. Basically, their heart is beating so fast, around 300 times a minute, and this isn't enough time for the ventricle to fill, and therefore the stroke volume and the cardiac output fall. So I've summarized these points here. At pathologic heart rates, there's very short diastole, there's a decrease in filling time, and therefore a fall in stroke volume. And the classic example of this is ventricular tachycardia, shown here in this EKG. This person's heart is beating so fast, the ventricle doesn't have enough time to fill, and therefore there's going to be a drop in cardiac output, and that's why people with VT can pass out. You won't see this when your heart rate goes up at the gym because it's never going to get up to 300 beats per minute. So this can be a confusing point, the relationship between heart rate and stroke volume and cardiac output. Watch the last couple of slides plus this one a second time if you need to until you get this straight in your head. And so on this last slide, I've summarized some important points about how much work the heart has to do. In other words, how much oxygen demand there is by the myocardium. The work of the heart is controlled by the same factors that we talked about controlling cardiac output. It's controlled by the preload, which, as we said before, can be represented by the left ventricular end diastolic volume or pressure. It's controlled by the afterload, which can be represented by the mean arterial pressure. It's controlled by contractility, which, as we said, can be represented by the ejection fraction, and it's controlled by heart rate. Sometimes in physiology textbooks, we define a term called the stroke work. This is the amount of work the heart has to do with each cardiac cycle, with each stroke cycle. And this is proportional to the stroke volume times the mean arterial pressure. Basically, if the heart is generating more stroke volume, that's more stroke work. And if it's generating a given stroke volume against a higher arterial pressure, in other words, more afterload, that also is going to lead to more stroke work. And anytime there's more work, more oxygen is used. And this will be very important in other videos when I talk about angina and ischemia, where the heart doesn't have enough blood supply to meet the oxygen demands. And then finally, you should be aware that anytime the heart is doing more work, it's going to extract more oxygen from the arterial blood, and therefore the blood that drains from the ventricle into the coronary sinus is going to have less O2. This is super high yield to understand for step 1 questions. When the heart works harder, the blood that enters the coronary sinus will have less oxygen in it because the heart is doing more work and it's pulling more oxygen from the blood with each cardiac cycle. And that concludes our video on cardiac physiology.